Welcome back to the deep dive. Today, we're embarking on a really practical dive into psychiatric nursing.
We are. We're focusing just on Chapter 5 of Varcarolis Foundations of psychiatric mental health nursing.
Exactly. And our mission here really is to quickly arm you with the framework you need to move past assumptions.
And get towards what the text calls culturally congruent care.
Which is just so vital.
It is, because the context we're all working in globally is often defined by stigma around mental health.
Right.
And that negativity, it doesn't just stop individuals from seeking help. It also, really impacts how resources get allocated. If you look at the national data here in the U.S., you see these major gaps, real discrepancies in who uses mental health services across different racial and ethnic groups.
And that gap, that's the challenge for nurses on the ground, isn't it?
Absolutely.
So before we can even think about bridging it, we kind of need to get our terms straight. Because words like race, ethnicity, culture, they get used interchangeably.
They do. And that causes a lot of confusion in practice.
Yeah.
So let's start with minority.
Okay.
We often think numbers.
Right.
Fewer people. But the book clarifies it's about groups defined by maybe different cultural or religious identities. And crucially, they might lack political or social power, even if they're, numerically speaking, not a minority at all.
Like women in some societies, as the text points out.
Exactly. Even if they're half the population, socially they might be in a minority position.
Okay, got it. Then there's race.
Yeah, and this one's complex. Historically, it was tied to biology, anthropology.
Right.
But now we really need to see it as reflecting social definitions, maybe national origins, sociocultural groups. It's fluid.
You just have to look at the U.S. Census, right? Trying to capture multiple heritage.
Precisely. It shows how society defines it. Then building on that is ethnicity.
So that's about shared heritage, history.
Yes, a common heritage and history. And what's really important here is that ethnic groups often share a worldview.
A worldview, like a lens for seeing everything.
Kind of. It's their fundamental system for thinking about how the world works, how people should relate, what's real.
Which leads us to the big one, culture.
The big umbrella, yeah. Shared beliefs, values, practices, all the stuff that guides how people think and act.
Including those really important cultural norms.
The norms that tell you what's normal or abnormal behavior within that group. Super important in mental health.
Okay, so these terms set the stage, but you mentioned worldviews shaping psychiatric perspectives.
That's right. The source talks about 3 major traditions, and understanding the sort of core differences between them is step 1.
All right, let's unpack those, starting with the Western tradition.
Okay, so this is rooted in Greek, Roman, Judeo-Christian thought. Identity is really focused on the individual.
Autonomy, self-reliance. That sounds familiar.
Very. But clinically, maybe the most significant part is Cartesian dualism.
The idea that the mind and body are separate things.
Exactly. That's why we often have separate doctors for physical health and mental health. It's baked into the system.
Okay, so contrast that with the Eastern tradition.
Big contrast.
Yeah.
Based on Chinese, Indian philosophy, Confucianism, Taoism, identity isn't in the self, it's in the family.
So more interdependence, group decisions.
Yes. And even time is different. It's seen as circular, not linear.
Circular. How does that affect views on mental illness?
Well, it can lead to ideas like maybe mental illness is a consequence of actions in a past life. And there's no mind-body split. They're seen as one unit.
Wow, okay. And the third one, Indigenous culture.
This emphasizes a deep, almost spiritual connection to nature.
Right.
Identity isn't really about the person as a separate unit. It's tied up in the community.
So less individualism again.
Much less.
Yeah.
And health is holistic. Body, mind, spirit, they're completely intertwined. Disease isn't just biological, it's seen as a lack of harmony.
Harmony with other people or the environment.
Both, with others or with nature, so you can see the potential clash, right?
Yeah, definitely.
A Western nurse, pushing for patient autonomy, runs straight into a cultural expectation where the family must be involved in decisions or where community consultation is needed.
And this friction, it probably shows up in really small ways, too.
Oh, constantly. Like in nonverbal communication. The book uses eye contact as a great example.
Okay. In the U.S., making eye contact generally means you're paying attention, you're engaged.
But in many other cultures, holding intense eye contact can come across as rude, arrogant, even a challenge to authority. A big sign of disrespect.
Huh. And touch, too, right?
Yeah, touch varies wildly. The U.S. is kind of moderate touch, but some cultures see casual touch as taboo, while others are very high touch. You can easily cause offense without meaning to.
So if we just assume our way is the right way in these
You
interactions,
fall right into ethnocentrism.
which is
It's basically the universal human tendency to believe your own culture's way of thinking and behaving is the only correct natural way.
universal, so
No.
we all do it.
Pretty much. The challenge for a nurse is recognizing your own ethnocentrism when you're interacting with a patient.
How do you even start doing that?
Well, one way is understanding just how different basic concepts like health can be. Our Western definition focuses on the absence of disease.
Right, and the patient makes their own choices. Confidentiality is key.
Exactly. Patient autonomy. But many other cultures define health as a state of balance or harmony
Balance it.
and decisions. They might not be private at all. They might be made by the whole family, focusing on protecting the patient, supporting the group.
So the family might even want to withhold a difficult diagnosis.
It happens because their priority is collective support. Also, some cultures believe passivity actually helps healing.
Which clashes directly with our expectation that patients should be active participants, take charge of their care.
Big clash. It requires a totally different approach.
Okay, so these are subtle interaction issues. What about bigger, systemic problems? The text mentions cultural barriers to care.
Yes, 4 major ones that stop people from getting the help they need. The first is communication.
Language, obviously.
Well, yes, but it's more than just language fluency. It's about needing a professional interpreter.
Not just pulling in a family member or a friend.
Definitely not. Especially in psychiatry, where topics can be sensitive, maybe embarrassing. Family members might filter information, or they might not know the precise medical terms.
Plus, idioms, right? You mentioned feeling blue.
Exactly. Translate "I'm feeling blue" literally into another language, and it makes zero sense. But it's crucial for understanding mood. The interpreter acts as a cultural broker, bridging that gap.
Okay, barrier 1, communication. What's number 2?
The huge weight of stigma.
We mentioned that earlier.
Right. And it's particularly heavy in cultures where family harmony is the absolute top priority. Mental illness can be seen as a failure of the whole family.
Leading to intense shame.
Profound shame, which makes people hide the problem, sometimes for years, delaying any contact with the healthcare system until there's a crisis.
That's a tough barrier. What's the third?
This one's critical for assessment. Misdiagnosis.
How does that happen?
Well, a lot of our standard assessment tools, questionnaires, things like that, they were developed and tested mostly on people of European descent.
So they might not be accurate for someone from a different cultural background.
They might not be. And this gets complicated by something called somatization.
Somatization. What's
Yeah.
that exactly?
It's when psychological distress, like deep sadness, anxiety, hopelessness, gets expressed primarily through physical problems.
So instead of saying, I feel hopeless,
Right.
someone might complain about back pain or fatigue.
Exactly.
Yeah.
Chronic back pain, stomach issues, headaches, constant fatigue.
Yeah.
The person might not have the cultural language or acceptance to talk about emotional pain, so it comes out physically.
And the risk is we treat the back pain but miss the underlying depression.
Big risk. We misdiagnose the physical symptom and miss the psychological root cause.
Okay, that's huge. And the fourth barrier.
This one's biological. Pharmacogenetics.
Genes affecting how people respond to medication.
Precisely. We now know there are genetic variations, often more common in certain racial or ethnic groups, that affect how bodies process drugs.
The chapter talks about cytochrome P450 enzymes, CYP enzymes.
Yes, over 20 of them. And they are responsible for metabolizing most of our key psychiatric drugs, antidepressants, antipsychotics.
So variations in these enzymes change how the drugs work.
Dramatically. Some genetic variations make people rapid metabolizers. The drug gets broken down and eliminated too quickly.
Meaning it doesn't have much therapeutic effect.
Right, you might need a higher dose than standard. Then you have poor metabolizers,
The drug hangs around longer.
much longer, and builds up. Imagine a patient is a poor metabolizer for, say, the CYP2D6 enzyme. They get a standard dose of an antipsychotic, but their body processes it so slowly, it's like they're getting triple the intended dose. The risk of severe side effects skyrockets.
Wow. So standard dosing just doesn't work for everyone.
Not at all.
Yeah.
We have to consider these genetic factors.
Right.
Though the text also cautions about some genetic testing claims being overblown.
Okay, so communication, stigma, misdiagnosis, somatization, and pharmacogenetics. Those are big hurdles. How does the system try to address the misdiagnosis part especially?
Well, the DSM-5, the diagnostic manual, actually incorporates culture more directly now, primarily through the cultural formulation interview, or CFI.
CFI, what is that?
It's a standardized set of 16 questions. It's designed to help the clinician understand the illness from the patient's perspective.
So less about just ticking symptom boxes.
Much less. It asks about the cultural meaning of the problem, what the patient thinks caused it, who they turn to for support, what kind of help they expect. It really tries to get at their understanding of their suffering.
That sounds like a really useful tool.
It is. It helps move away from just imposing a diagnosis toward understanding the person's experience in their context.
And this relates to what the text calls cultural concepts of distress.
Exactly. That term replaces the older, somewhat problematic culture-bound syndromes. It refers to the ways different groups experience, understand, and talk about suffering or problems.
Okay, and there are different types of these concepts.
Three main types. First, cultural idioms of distress. These are specific ways of talking about suffering, like saying, I'm a nervous wreck or I feel broken.
So common phrases within a culture.
Right. Second, cultural explanations or perceived causes. This is how a culture explains why someone is ill. It could be social, natural, or even supernatural causes like spear possession.
And the third?
Cultural syndromes. These are clusters of symptoms recognized within a specific culture as a coherent illness or condition.
Can you give an example?
Sure. The text mentions hwa-byung. It's a Korean syndrome, often linked to suppressed anger. Symptoms include things like insomnia, fatigue, panic, indigestion, but often a denial of actual sadness.
So physical and emotional symptoms, but understood differently within that culture.
Precisely. Another example is ataque de nervios, found in some Latin American cultures.
What does that look like?
It's often triggered by intense stress, like a family death or conflict. It involves sudden trembling, heart palpitations, shouting, maybe fainting or temporary blindness. It looks dramatic.
I can imagine that being mistaken for a purely medical emergency in the ER.
Absolutely. I remember a case discussion about that a patient having an attack was initially treated as having a seizure or heart attack.
Huh.
But once the cultural context was understood, maybe using the CFI, the nursing care shifted completely. It became about validating their way of expressing overwhelming stress.
That really highlights the need for cultural understanding. Before we get to the how-to of providing better care, the text mentions special at-risk populations.
Yes, important distinctions here. First, immigrants.
What are their specific challenges?
Well, there's the stress of navigating a new country, new systems, maybe loss of social status or professional skills not being recognized. Then there's acculturation.
Learning the new culture.
Right, learning and adapting. And sometimes assimilation, which is more about fully absorbing the new culture, maybe losing parts of the original one.
That sounds like it could cause friction within families.
It often does. The text calls it intergenerational conflict. Kids often pick up the new language and culture faster than their parents or grandparents, which can create divides and misunderstandings at home.
Okay, so immigrants. Then there are refugees. How are they different?
The key difference is refugees flee their home country because of intolerable conditions, war, torture, persecution. They didn't choose to leave in the same way an immigrant might have.
So the trauma is imposed on them.
Exactly. Their stress isn't just about adapting. It's often rooted in severe trauma they've experienced or witnessed. This leads to much higher rates of PTSD, depression, anxiety.
That's a critical distinction for care. And the last group.
It's not really a cultural group, but a socioeconomic one. People living in poverty.
Okay.
The source is very clear here. The high rates of mental health problems are overwhelmingly linked to poverty. And the constant stress of survival, lack of resources, unstable housing, poor nutrition, exposure to violence, not inherently to race or ethnicity.
So poverty itself is a massive risk factor for mental illness.
Exponentially so. The stress burden is immense.
All right, so we've got the terms, the worldviews, the barriers, the at-risk groups. How do we actually do better? What's the goal?
The goal is culturally congruent practice. That means providing care that's evidence-based, but also fits with the patient's own values, beliefs, and practices.
And the process of getting there is cultural competence.
Right. It's not a destination you arrive at, but an ongoing process. The text highlights the Campinha-Bacote model as a good framework for this.
Campinha-Bacote, what does that involve?
It views nurses as needing to be continuous learners across 5 areas or constructs. There's cultural awareness, cultural knowledge, cultural encounters, cultural skill, and cultural desire.
Okay, 5 things. Let's zoom in on the practical side, maybe cultural skill. What does that look like day to day?
Well, a huge part of it, as we said, is ensuring good communication. That means using professional interpreters. But beyond that, it's about the assessment itself.
How you ask questions.
Exactly. The text brings up those classic questions from Kleinman and his colleagues. They're simple, but powerful.
Remind us what they are.
Basically, what do you call this problem? What do you think caused it? Why do you think it started when it did? What does it do to you? How severe is it? What do you fear most about it? And, crucially, how do you think it should be treated? What results do you hope for?
Asking those really centers the patient's own perspective, doesn't it?
Completely. It lets their cultural lens guide the care planning. It shows respect for their understanding.
And that leads into the care planning framework the book mentions, from Webby Alama.
Yes, it suggests 3 potential nursing actions based on the patient's cultural practices. First is preservation or maintenance.
So supporting things they do that are actually helpful.
Exactly. If strong family support is part of their culture and it helps them cope, you actively support and encourage that.
Makes sense. What's the second action?
Accommodation or negotiation. This is for cultural practices that are neutral, neither particularly helpful nor harmful from a medical standpoint.
Like using certain folk remedies, or consulting a traditional healer alongside medical treatment.
Precisely. You accommodate those practices, maybe negotiate around them, as long as they aren't causing harm or interfering with essential medical care. Like coining or cupping might look alarming, but usually harmless.
Okay. Preservation, accommodation, and the third.
This is the trickiest one. Repatterning or restructuring.
That sounds like intervening.
It is. This is when a cultural practice is genuinely harmful or conflicts significantly with the treatment plan.
But wait, if we're supposed to be culturally sensitive, how do you decide when something crosses the line from neutral to harmful? That seems like a really fine line.
It's the most complex negotiation, absolutely.
Yeah.
It requires careful assessment and communication. Think of it like a therapeutic trade-off or finding a middle ground.
Can you give an example?
Okay, say a patient strongly believes in using a traditional herbal tea to manage anxiety, but you know that herb interacts negatively with their prescribed antidepressant. You wouldn't just say, stop drinking that tea. You'd explain the interaction clearly. You might negotiate, okay, you feel the tea helps you. Could we agree you won't drink it within, say, 4 hours of taking your medication to minimize the risk?
So you're respecting their belief, but restructuring the practice for safety.
Exactly. You're repatterning it to make it congruent with safe, effective care. It takes skill and trust.
And underlying all 5 constructs, awareness, knowledge, encounters, skill is the last one.
Cultural desire. This is the foundation, really. It's not about having memorized facts about every single culture. That's impossible.
So it's more about attitude.
It's the genuine motivation, the interest, the empathy, the wanting to provide culturally responsive care. It's being willing to learn from the patient, to be humble, flexible, and respectful. That desire is what drives you to develop the other areas.
That's a great way to frame it. The desire has to be there first.
It really does.
So, wrapping this up, key takeaways seem to be understanding those different worldviews, recognizing the barriers like stigma and misdiagnosis, using tools like the CFI.
And applying a structured approach like Campinha-Bacote's model, always starting with that cultural desire.
Okay, so here's a final thought for you, our listener, to chew on based on everything we've discussed from this chapter. We know that mental illness is often defined by what a culture considers normal versus abnormal behavior.
Right, deviance from the norm.
So if that's the case, what are the real implications, good or bad, when we apply a formal psychiatric diagnosis, one mostly developed within the Western tradition, to someone whose behavior might actually be considered perfectly normal, or at least understandable, within their own cultural context?
That's a deep question. It really pushes us to think about the power dynamics and potential biases inherent in diagnosis itself.
Something to definitely keep reflecting on.
Absolutely.
Well, thank you for joining us for this really essential deep dive today.
Glad to be here.
We'll see you next time.